Good morning and welcome to day 3 of the 2022 Pennsylvania Black Health Matters Conference, Disrupt and Build Up. Today is Women's Wellness Day, and we are so glad that you are joining us for our first session of the day. It is Understanding Colorectal Cancer, and it's being brought to us by the fabulous Beth Simon. She's the Cancer Control Specialist of the Office of Health Equity, Education, and Advocacy at UPMC. She's going to start presenting in a moment. If you have any questions, be sure to pop them in the chat, and she'd be more than happy to answer any of those after the presentation. Thanks so much, and I will hand it over to you now, Beth.
Okay. And my tech support is here.
That's important.
Hi, my name is Beth Simon, and I work in the Office of Health Equity and Community Outreach and Engagement at UPMC Women Cancer.
Did you want to start it from the beginning, or is it? Because I'm not able to hear the sound. Do you hear it on your end?
I can hear it.
Okay. All right. You just let me know when you're ready for me to bring it back up. Oh, you're
22.
There we go. So we will get started again in a moment, folks. Okay, so don't go away. We'll have this presentation going shortly. Thank you so much for your patience. Okay, we are ready to start back up.
I'll let you know.
And here we go. Alrighty.
Hi, my name is Beth Simon, and I work in the Office of Health Equity and Community Outreach and Engagement at UPMC Hillman Cancer Center. Today, I will be providing information to you about colorectal cancer. We will be emphasizing the signs and symptoms, screening, and early detection. After the lecture, I will have a question and answer session, so feel free to ask me anything that you would like. CRC stands for colorectal cancer, which is cancer of the large intestine and the rectum. It is the third leading cause of cancer in men and women. You can see the stats on the slide. In 2022, it's estimated that there will be over 52,000 deaths from colorectal cancer, and some of these deaths are preventable. The incidence and mortality, which is the number of new cases and the death rates, are declining in individuals who are over 50 years of age, but they are actually increasing in those who are under 50. and Black men and women have the highest incidence and mortality for colorectal cancer. And research suggests the most important factors in this disparity are access to high-quality screening and cancer care, not biological issues. So what are the risk factors for colorectal cancer? And a risk factor is something that increases your chance of developing colorectal cancer. It doesn't mean that you will get it, but it increases your risk. Some of them are modifiable risk factors, which are actually things you can do something about. There may be lifestyle factors such as excess body weight, being inactive, not getting enough exercise, eating too much red meat, drinking too much alcohol, having a diet that's low in calcium, and a diet low in fruits, vegetables, and whole grains. So as you can see, just some of these lifestyle behaviors that increase your risk for colorectal cancer are things that increase your risk for other types of chronic diseases such as heart disease and diabetes. So the risk factors for CRC are similar to risk factors for other diseases. And then, of course, there are some risk factors that are not modifiable. For example, if you have a family or a personal history of colorectal cancer, or if you've had certain types of polyps in your family or in yourself. If you have a personal history of chronic inflammatory bowel disease, and that is people who have ulcerative colitis or Crohn's disease, those are inflammatory bowel diseases. And usually individuals with inflammatory bowel disease are followed very closely by their physician. People with type 2 diabetes also have an increased risk for colorectal cancer. Now, what are the symptoms for colorectal cancer? Well, in an early stage, colorectal cancer often doesn't cause any symptoms at all. And that's important to know because it will help you understand why you should participate in screening for colorectal cancer, even if you feel fine. A lot of us, I don't have any of it in my family, I feel fine, I don't need to get checked out. But again, most of these early cancers do not cause any symptoms at all. When you do see symptoms, they're generally rectal bleeding, blood in the stool, change in bowel habits. If you all of a sudden have diarrhea or constipation and that's not normal for you, that could be a sign that you need to get checked out. Having a narrowing of your stool, abdominal pain or cramping, having a decrease in your appetite, and weight loss are some common colorectal cancer symptoms. They can also be symptoms of other things, but don't ignore them. Just get them checked out. So if people are at an average risk for colon cancer, and we will talk about that in the next slide, screening should start at the age of 45, and they've just lowered that from 50. So starting at the age of 45, you talk to your doctor about what screening test is best for you. And continue to be screened at the interval determined by your doctor, at least until the age of 75. And then after 75, share in decision-making with your healthcare provider about how often you should be screened. And the interval between screening times is determined by the results of your prior screening and your personal or family history. So if you were screened for colorectal cancer and it was a normal test, they didn't find anything, they will let you wait longer until the subsequent test. Conversely, if they found some polyps and had to take them out, they may suggest you come back more often. than somebody who did not have anything abnormal in their test. So the communication between you and your doctor is very important for this. So what is average risk for colorectal cancer? Well, it means that you've never had colorectal cancer or certain types of polyps. So no colorectal cancer, no polyps in the past, puts you at average risk. If you don't have a family history of colorectal cancer, no personal history of ulcerative colitis or Crohn's disease, no hereditary colorectal cancer syndromes, and those include two syndromes. One is known as FAP, familial adenomatous polyposis, where people have a lot of polyps in their colon at the same time, or another syndrome called hereditary non-polyposis colon cancer. Those are both caused by genetic defects and pass through generations. And if you don't have any personal history of getting radiation to your abdomen or pelvis, these factors put together will put you at average risk, which means you would start screening at age 45. So if you have any of these factors, then you would need to talk to your doctor about your family history, and you will determine how early you should be screened, if you should be screened before the age of 45, and if you should be screened more often. So for example, if somebody in your family was diagnosed with colorectal cancer at age 45, you would not want to start screening at age 45. You would want to start earlier, because colorectal cancer can take several years to grow before it's detectable. So it's important to talk to your doctor about your family history, particularly if people in your family are developing colorectal cancer or other types of cancers follow this as well at an early age. You may be at higher risk. So what are the screening tests for colorectal cancer? Well, there's some stool-based tests which have recently become much more popular as they've gotten a lot more sensitive. One of them is a fecal immunochemical test, and that's done every year. And highly sensitive guaiac-based tests yearly are done as well, and then stool DNA tests every 3 years. So these are 3 options for at-home testing, which is private, and you send it into a lab and then you get the results. Now, the thing with this is that if you get an abnormal test result, you have to follow up with a timely colonoscopy, because these tests can't tell you whether it's a polyp or a cancer or what type of polyp it is. It's just telling you that there's something that's not normal and that you should get a colonoscopy. So that's important to know. And here's a couple of pictures. The one on the left is the InSure test. It's immunohistochemical test. And then you probably recognize the cartoon on the right. It's the Cologuard guy who comes in the mail and talks to you about colon cancer and then goes back in the mail after you have done the test. So these are very popular tests. They're very good tests. Again, if they're positive, then you need to get followed up. The other types of tests are the visual exam tests. The most common and popular is the colonoscopy, and that's done at least every 10 years, depending on what they find. There's a CT colonography, which is called a virtual colonoscopy. That's done in the CT scanner and is done every 5 years. And then a flexible sigmoidoscopy is basically a shorter colonoscopy. It examines only the lower part of your colon, which is the sigmoid colon. And that should be done every 5 years. Now, except for the colonoscopy, any abnormal test results, again, should be followed up with a timely colonoscopy. So if you do opt for the CT colonography or the flexible sig, you will need to get a colonoscopy if there's any abnormal findings. This is a picture of a colonoscope. It's a fiber optic scope that allows for biopsies to be taken, polyps to be removed through the scope while the physician is looking at your colon. So basically, this is inserted under sedation. Usually, people just sleep through this exam, and they visualize the lining of your intestine. And if they come across a polyp, they can remove it through the scope. And you don't feel that at all. Actually, most people don't feel this exam at all. It is under sedation. Colonoscopy is the gold standard. And as I said, the main benefit is that it allows for the removal of polyps during the procedure. It can also detect diseases such as inflammatory bowel disease, which we talked about is Crohn's and colitis, and also diverticulosis, which is a common disease of the intestine, especially as people age. That can be seen through the colonoscope as well. Proper prep is very important. They are looking directly at the lining of your intestine. So if there's stool left in your intestine because of an incomplete prep, they won't get as good of an exam. So it's very important to make sure that you follow the instructions for the preparation. Now, the preps have changed, and depending upon who is doing your screening exam, different physicians like different preparations. One of the ones that is a lot more common now is the Miralax prep in Gatorade. That's one. There's the Sue prep, which is also, it can be, this is liquid that you see here, but there's also tablets. So it's really up to your physician, their choice, from their experience, what gives the best prep, and that's what they will ask you to do. Again, it's very important that you get cleaned out. The day before your colonoscopy, you will be asked to only drink clear liquids, so clear broth, clear juice, water, things that aren't red in color, but things that just can go through you, so that there's, you're not making stool that would hinder the examination. Okay, so when they do find colorectal cancer, the most common treatment is surgery. And a lot of people think that surgery means that you're going to have a colostomy, where the bowel comes out of your abdomen and you have to wear a bag. In actuality, colostomies are seldom needed for colorectal cancer. The surgery is usually that they remove the cancer and then they put the two parts of the colon back together and restore normal bowel function. If the cancer has spread, they often give chemotherapy, and they have very good luck with chemotherapy in colorectal cancer. There's new drugs that have been developed over the years that are very good. For cancer that is in the rectum, which of course is the lower part of the colon, they use chemotherapy plus radiation therapy when they need to give treatment. So people with colorectal cancer have a very good survival rate. For all stages together, that includes early and late stages, there's a 65% 5-year survival rate. Of course, it's higher for early stage disease, it's up to 91%, and then lower, of course, for later stage disease. But what we like to see is that people are getting their colonoscopies, doing their stool tests, so that when it's detected, it is detected at a very early stage where you get the really high survival. And these tests are very good at doing that. So that's why screening is so important. So if anybody has any questions about screening or is afraid of it, just know it's a simple procedure. If you do the colonoscopy, it's done under sedation. The prep really isn't all that bad. But if you aren't sold on that and you want to do one of the stool-based tests, they're very convenient. Just know that you have to get a follow-up colonoscopy if there's anything abnormal. But when people ask, what is the best test for colorectal cancer? The answer is whichever test you will get. So it's really important to be screened with whatever test you get and then follow the recommendations of your healthcare team. Thank you very much, and I will be around for questions if you have any.
Hi, Beth.
Hi, can you hear me?
Can you hear me okay?
I can hear you. Can you hear me?
No, I'm not able to hear you.
Hang on a second.
I know we're almost at 11 o'clock. I did want to throw up. There were just a couple of questions. One was, what should people do who perhaps don't have insurance? Are there resources out there for those individuals?
Are you able to hear me, Nicole?
So we still can't hear you.
Bob just checked the settings here.
All right.
How about now?
I think that was my end. Yep, I'm good.
Yes. So, people who don't have health insurance, there are ways to get, particularly the stool-based tests, for free, and physicians should have access to them. But if not, it depends on where are you in the state and what are the resources for that. But yes, you should be able to be screened. Insurance should not limit you.
Great. All right.
Yeah, and I could give that person more information if you want to share my email address with that person.
Sure. And the person asked that question, if you want to go over to our speaker section, you'll see Beth's contact information there. It'll be attached to this particular session.
And the other question about feeling the scope, yeah, it's because of the anesthesia. If you didn't have the anesthesia, you would feel quite a bit of cramping. It wouldn't be pain, but it would be cramping because the scope is actually in your colon. It doesn't hurt later. The only thing is they do use air to inflate the colon. So sometimes you can have some pain from having the air in your colon for a while, but that goes away. I'm so sorry about the problems, but we did it.
Everything is good. We are here. We got it done.
We did it.
Yes.
Thank you, everybody, for your patience.
Yes, it is all fantastic. Thank you so much, Beth, for sharing your expertise with us. We really, really appreciate it. We will record this. We'll edit it a little bit and make sure that it's available for folks to watch later on. And then we'll also have a version of it on our YouTube site, Disrupt and Build Up, sometime next week.
Okay.
So thank you again, Beth, so much. And I will be talking to you in the very near future.
Okay. Take good care. Bye-bye.
All right. And thank you to all the attendees who are watching. We're going to continue today's conference with our next session, our journey to medical school, with Brittany Henderson and Zahara Peters. So that will start up momentarily. So be sure to stick around for that. You can search for that one in the sessions area, and it should be going live in a moment. All right. Thanks so much. Bye-bye.